Welcome back to the Grand Rounds online lecture series. I'm Grace Lagase, one of the emergency medicine residents at the University of Cincinnati Medical Center. In this lecture, we'll be discussing part 2 of the vascular ultrasound, the lower extremity venous system, specifically focusing on the proximal deep veins. Following the venous system proximally to distally, the iliac vein becomes the common femoral vein, which splits into the deep femoral and superficial femoral vein. The greater saphenous vein comes off of the common femoral vein. The superficial femoral vein then runs deep and distally, ultimately becoming the popliteal vein. It is important to note that all of these veins are part of the proximal deep venous system. You can see a representative image on the right of your screen. When examining the proximal deep veins of the lower extremity, we focus in the emergency department on the branch points in the deep venous system. This is because increased turbulent flow occurs at branch points. This turbulent flow can damage vessel walls and predisposes branch points to clot formation over other areas of the deep venous system. In order to adequately examine the lower extremity deep veins, according to ASAP guidelines, it is essential to perform limited compression of the deep venous system in two areas, at the junction of the common femoral vein and the greater saphenous vein, and in the popliteal fossa. Compression occurs when you are able to completely collapse the venous structures with applied pressure. This means that you're able to see the venous walls oppose each other. If you cannot perform this task and you begin to deform the arterial structures, this is abnormal and suggests a clot. The exam is performed using a high-frequency linear array probe. An example is shown here. An adequate exam is performed using the linear array probe in the transverse view. For our more rotund patients, you may need to use the curvilinear array probe for deeper tissue penetration. In order to adequately examine the common femoral and saphenous junction, you must compress the junction in three areas: above the common femoral and saphenous junction, at the level of the common femoral and saphenous junction, and below the level of the common femoral and saphenous junction. At the level of the common femoral and saphenous junction, you see the femoral artery and the common femoral vein next to each other. This is an example of the right leg. At the level of the common femoral and saphenous junction, you will see the greater saphenous vein branch off of the common femoral vein. Below the level of the common femoral and saphenous junction, you will see the superficial femoral vein and the deep and superficial femoral arteries. This is approximately achieved by moving the transducer 1 centimeter to see each of these three separate compression areas. Here's an example of adequate compression performed above the level of the common femoral and saphenous junction. You can see that with adequate compression, the common femoral vein collapses completely. The common femoral vein is outlined in blue, and with pressure, you can see complete apposition of the venous walls. To adequately examine the popliteal fossa, 1-point compression is required. However, it is important to evaluate the entire fossa for venous compression. Often throughout the popliteal fossa, you will see the vein above the popliteal artery. This is known as pop on top. This is an example of adequate compression performed in the popliteal fossa. You can see the collapse of the popliteal vein. The popliteal vein is initially outlined in blue, and then with compression, you can see the apposition of the venous walls. Thank you for watching the online Grand Rounds lecture series on venous ultrasound.